Thank you.
And I just wanted to welcome and say thank you to Danielle. So this is CPS Echo, and so we've expanded our audience a little bit for this Echo because the topic cuts across so many different kinds of people interfacing with our folks involved with CPS, and there's a lot of confusion about the various ways to screen for substances and then how to interpret those screens. So we really are looking forward to your talk today. Thanks.
Thank you. Yes, so yeah, when I was approached with a couple of questions, and I get them a lot, I get them through Epic, I get them through email about various findings from laboratory results, and what does this mean? What does this look like? Because that's part of my capacity here at Ruby, is as a consultant for the WVU medicine system with regard to testing. I just, it was, hey, would you speak? And I said, oh, absolutely. I've come and spoken at Echo before and happy to do that. Let me see if it's, can you see my slides and are they advancing and moving?
Yes.
Okay. Yes. Okay. So I didn't start out on slide 1, but we all know why I'm here. So I'll just move to disclosures. I don't have anything to disclose. One thing that I do professionally is I don't sign contracts with manufacturers. I don't become a spoken paid person for them. So the opinions I give are mine. And I like to keep it that way so that I can be completely open about my experiences with testing and the like. So this is what I plan to talk about. I know that there aren't great primers out there. Being from Texas, it's primers, not primers for me. But there aren't a great number of indices about what these terms mean. So in the capacity I'll be speaking of them, I'm presenting a few terms, then talking about options regarding testing, because until, we can't really talk about interpreting a screening test until we kind of get those basics under us, then getting to those test results and what the reports look like, kind of the anatomy of this and that. And then what labs can and cannot do. That's something that I get asked a lot. Can you do these things? And sometimes it's, yeah, sure, I'd love to help you with that. And other times it's like, that would be highly restrictive for us. And these are why. And then I had hoped this would only be about 20 minutes. I would like to keep it restricted so there's plenty of time for Q&A, because I think that there's a lot more gained from that. And then at the end, and the slide deck will be coming to you, I have a couple of references that I always recommend. They're excellent tools. And I just sort of, I hope everybody has access to them. If you don't, I'll give you PDF if you email me or message me. So I think they're really useful references. So now getting to the terms. When we're talking about testing, you hear these terms and you see them in the catalog, screen. Everybody kind of knows what screen is at this point, but what's the difference between a screen and a confirmed test, or a confirmatory and a definitive test, especially the difference between definitive and confirmatory testing? That gets kind of tricky. So I made my giant table. I'm a big giant table person. Screening tests are typically rapid. They're typically targeting one drug like cocaine, or a class of drugs like benzos or opiates. So you can have a blend of those in a drug screen, and depending on what drug you're looking at, what class, you can have these cross-reactivity issues, where I'll talk a little bit more about cross-reactivity and that concept. But this is where we get sticky with interpretation of some of the screening results we see. The utility, if you need a test rapidly, you're usually going to get a screen, because that is kind of how it's tooled. That's how it's intended. The results of screens are often qualitative because of their nature. We aren't 100% certain of the results because of these factors going on in the background. And they're often driven by immunoassay tests. The drug cups all the way into testing laboratories these days, still mostly immunoassay driven testing. There's some exciting work that is being done in San Francisco, Toronto, and some other sites that's bringing definitive level testing to the screening step and making it faster. So I hope I see this in my career. It often takes a long time because the technology is expensive and demanding. Then when we get to definitive testing and confirmatory testing, confirmatory tests are definitive, but not all definitive tests are confirmatory. So when you look at the rapidity of the test, most of the time, these two are not very rapid. They usually take quite a bit of time, quite a bit of prep. There's a lot of standards in the background, especially for confirmatory level tests. If I want to know if fentanyl is present, I put a fentanyl standard In the run, I do a calibration for fentanyl. So anything that looks like fentanyl, quacks like fentanyl, we call it that, and we can ascribe a number to it. Whereas in the definitive testing world, the analyzer knows what fentanyl looks like and quacks like, and it says that matches fentanyl, but it doesn't necessarily give you a number. So that's kind of that contrast. So in terms of cross-reactivity, you don't have a lot of that. Only if you've got these weird left and right spin type molecules. Some of the amphetamines are a problem with that. Do you get those weird kind of strange signals? In terms of utility, you're seeing on the table that you're moving into compliance territory. You're like, I need to make sure that this is there, or I need to make sure that this is not there. So those are the questions you're asking. And then the results in the definitive realm, often qualitative, like I said, and then confirmatory, you get into semi-quantitative and quantitative methods, depending on the application. And then what you see too is that we've moved away from immunoassay and we're moving into mass spectrometry. And everybody knows the word mass spectrometry. It's the mythical unicorn beast of testing, but it's that next level of stringency in terms of testing. So I mentioned in the table that there's a library that's used in definitive testing. And I don't mean a bunch of books, although that's a nice picture to bring into your mind. If you think of a library with all the books, what we use in mass spectrometry and in the definitive world is a library of molecular fingerprints. So someone somewhere has fed a compound through a mass spec and gotten its signature for that technology and stored that into a book in that library. And you can store thousands and thousands of drugs and compounds that way. And then when you push a sample through the system, if it can identify a single compound or a mixture of them, it will tell you, I got library hits on these compounds, and it'll tell you the level of certainty that it has in the match that it found. The more mixture you put at it, the harder it is to make a definitive match. But you know, it's kind of like what they do in microbiology now with mass spec too. I'm 99% certain that this is Staph aureus. I'm 100% certain that that's cocaine, but I'm about 4% certain that it's lidocaine because it doesn't look right. So something like that. And this was really born in drugs in the GC mass spec world in forensics. So everybody's kind of heard of this. They've heard of the library. They've heard of this concept. But I wanted to kind of give you that picture so that maybe if anybody ever says we had a library hit for X, you go, I know what you're talking about. So there it is. All right, then cross-reactivity, this other concept that I was talking about. Cross-reactivity can occur when compound X interacts with a system that's supposed to detect compound Y. And this is for same class drugs. If your oxycodone method is relatively robust, you shouldn't have cross-reactivity with other semi-synthetic opioids, but you might see some. So something structurally similar might have a handshake with that method and say, hey, I'm present, and it'll look like oxycodone on the result, but it might not actually be oxycodone. We see this too with opiates, benzos, definitely THC has some cross-reactivities with herbal supplements, not what you think. And there's little blue pills out there that people take commonly that cross-react with PCP assays and THC assays. So you get these very strange situations where a person who's completely innocent of taking an illicit compound gets a positive and they're very alarmed, or you are, you know, and you're saying, what is this about? It could be about cross-reactivity. And cross-reactivity can be positive or negative. You might be expecting a class compound to give you a positive benzo like alprazolam, but it weakly interacts with that test because something else was used as a calibrator. So you would have to really take a lot of alprazolam to ping that positive, whereas the calibrator test would hit right at where you need it to. So this is a very squishy world, and this is where I get a lot of my questions is about cross-reactivities. Are there any questions so far about this?
So I posted something. Go ahead. I posted something in the chat just about false positive and false negatives rates, like either for the rapid screens or the other kinds of screens.
Yeah, thank you, because I can't see the chat, so that's very helpful. yeah, this is exactly what underlies those rates of false results. And well, that's one part of it. False negatives can also happen if you've got a person who's maybe not taking at the same frequency or dose that they should be. So it's like a squishy non-compliance. They are technically still taking the compound, just not at the inferred rate. That's a false negative. False negative rates are much harder to characterize for a test than false positive rates, because I can sit down and look at false positives in a report. I can pull that out of Epic. There was a positive here. Oh, wait, it was this other compound, and I'm seeing a pattern. And I've done this for the emergency department. When we launched our fentanyl screen at 1 nanogram per mil cutoff, like the lowest cutoff we have by a mile on our drug screen, ED said, this test is terrible. And I said, no, actually, it's just too good. It's just it's a little too sensitive. And they said, we're getting a lot of false positives. Clearly, these patients are not obtunded. There's nothing wrong with them, but we're getting FENs. And I said, I have an idea what that is. And I went into the charts, and beta blockers and antihistamines are commonly cross-reacting with the fentanyls. So we say, you know, in a patient where you have a suspicion, in a patient that a population that is sensitive, like OB, they confirm any fentanyl positive because they use a lot of labetalol, and it definitely cross-reacts with fentanyl and gives a false positive. So we know the rates for false positivity much more commonly than false negative. It's a good question. Thank you. Anything else before I move on?
Just if you can share with the audience what labetalol is typically prescribed for, because that's a really common false positive for fentanyl.
Yes. Hypertension associated with pregnancy is a big one. So when you've got pregnant patients, labetalol is relatively gentle. It helps control blood pressure. It helps bring that hypertension, you know, that blood pressure into control. And so naturally, these mothers are highly alarmed when they see a fentanyl positive screen, and they're like, I'm really not taking this. And the providers know, and they go, well, we're going to confirm it just to be safe. And, you know, 99% of the time, there is no fentanyl in those particular cases. So yeah, it's one of those cases where when you have a concept where screening is indicated because you're trying to protect the population, you end up with a lot more false positives because, you know, you're opening the gates and there's all these other things in the background. So yeah. Okay, moving on. Yeah. Good. Okay. All right. So examples of cross-reactivity. In my package inserts, this is what comes out of the FDA approval and into the packaging that we get with an assay. And you'll see it in your slide deck, you know, up close, because I know the fentanyl table is very tiny print. But what we get is information about which drugs cross-react with what strength. So on the left is my opiate assay. It is calibrated with morphine. And at morphine 300 nanograms per mil, we will get a positive result end up. But if you notice, when we have 6-monoacetyl morphine there, 280 will cause a positive. So it's slightly more cross-reactive. It's slightly more affinity for the antibody than even morphine itself. Same thing for codeine. 180 nanograms per ml of codeine will give you a positive on a 300 morphine screen. So those are strongly cross-reactive, and they like to show their faces. Whereas dihydrocodeine, you've got to take double, past double to get a positive. So you've got to take a pretty strong dose. So people could fly in under the radar by taking DHC and at a therapeutic level, and you won't catch it on that screen. You'll be like, this is a potential false negative. Exactly, because of cross-reactivity in the negative. Then you look at some of these other compounds, hydromorphone, 1400. It's barely interacting with the antibody in the assay. You'd have to get a pretty high dose there to kind of trigger it. And you move down the table, 10,500 of oxy is needed to trigger an OB positive. This is the most common false positive I see in the opiate screen per what we do in our confirmatory world. So every time I pull our oxycodone confirmatory tests and I'm checking its accuracy, I see a lot of opiate positives that came back negative for opiates, but positive for oxy. So that is a cross-reactivity we do see in patients who are taking clinical levels of oxycodone. So these are some examples of the cross-reactivity we see. Fentanyl is calibrated. That screen is calibrated by fentanyl. So if it's metabolized to norfentanyl, I'll give you a pointer. Norfentanyl is somewhere way low on this table. Oh, here it is. 20,000 nanograms per mil of norfentanyl are needed to give us a fentanyl screen positive. So it's tuned only to see pure fentanyl. And then you look at the other fentanyls there, and you see that there's some variations in cross-reactivity, and you notice that there are many that are not present, like carfentanil. So these assays are designed to interact with some things. They're not well characterized beyond the FDA approval. Sometimes I can contact the manufacturer and say, hey, do you have any cross-reactivity data about carfentanil? And I can keep a record of that in my lab so that if anybody asks me, I can be like, yeah, that doesn't cross-react. Or yeah, it does, but only if it's 50,000. Yeah, some crazy number like that. So this is information that I'm always using in the background. I'm always pulling package inserts. I'm always kind of referring to what did the manufacturer say about how this behaves when I talk to folks. And then here's some examples of clinical scenarios that might come up based on this information that we have so far. So if a drug present in specimen is codeine, we might get an opiate pause on that because it strongly cross-reacts, right? And the definitive test may also say codeine is detected. So specifically codeine is detected, but the screen would only say opiate positive because it's like, I don't know which one it is. It's just pop. Get to a definitive, it's like, yeah, I can tell this is codeine. And then in my lab, we have the calibration, the fingerprint, the internal standard, and we say, yep, it's codeine and it's present at 432. So depending on the clinical needs, you might see these different reports. And then moving down the table, in this particular scenario, I have an oxycodone that's weak by confirmatory at 48. So in this case, opiate was neg, oxy was pos. If we put it into a definitive, it would just say, I detect oxy. And then we say we detect oxy at 48. Then moving on further, I'd like to point out carfentanil in this table. Opiate and oxy and fentanyl would all be negative. So they would look absent. If you had a definitive method access, which we don't here, there are a few we can get, but it takes days, so it's not terribly useful in the short term. It would say carfentanil is detected. But if it went back to my lab, I wouldn't be able to detect it. I wouldn't find it. So we have to know our assays and we have to know what components are present because my confirmatory will only find the compounds I tell it to look for. Okay, so this is an important point. A lot of laboratories like mine that have brought in clinical mass spectrometry, we do confirmatory with panels. Anything outside the panel, black box. So it might be a false negative just because of inference. So, all right. Alprazolam is, like I said, I pointed it out early because it's been an interesting, sticky little drug that shows up here and there. And they say, I know the patient's taking it, but it's not showing up anywhere. I'm like, yeah, because it's present at 4 nanograms per mil and we can't detect it. So anyway, any questions about what you glance at here on this table? Nothing? Okay, we'll keep moving so that I can keep us going. So the options and considerations when we're talking about drug testing, the word matrix comes up in the lab all the time. We talk about matrix like, you know, everybody knows what that is. And I used to have a picture of Keanu Reeves bending with the bullets coming over him. And a lot of people don't know what that means now. So I don't use it anymore. But matrix in its definition is a natural incomplete specimen. That's all it is a complete blood, a complete urine, a complete hair specimen. That's the matrix we're dealing with. And they vary widely, of course, by the fluid and what we're being presented with. So when we create a method, we have a matrix in mind. For example, my confirmatory method is for urine. If someone threw serum at me, it probably wouldn't work the same. One, I'd be looking at different drug concentrations. I would have to purify it in another way, and we aren't geared for that. So it would take regulatory hoops for us to get there, and that can take us years because we move kind of slowly in terms of how we build these things. We only have a couple people at the bench, so there's just not a lot of wavelength for us. Whereas other labs can be more nimble, and they like, yeah, we've validated this in 15 different matrices. That's an MS. That's why I recommend them all the time. I say, my friends at NMS can get just about any fluid you want and detect almost any drug you want because they've done the work and they have the volume coming in to help them with that. Anyway, so we have to consider where a drug is going to be, where it's going to go, how long it's going to be there, etc. So which matrix you choose and which drugs are paired with them can depend a lot, one on the matrix, two where it's expected to be in over time. So I have a timeline at the bottom of the screen that starts in minutes and then moves into years. And you can see the different matrices might be a little bit small, but in minutes we have circulation. So we could do blood testing, some oral fluid and sweat would be three matrices that would have kind of an immediate sort of response to the absorption, right? Because it's the early carriage and excretion of the drug. As we move into hours, we see drugs appearing in urine and other tissues like umbilical cord, which we send out to another laboratory, but it is a common additional matrix that we see at Ruby that comes through the lab for drug testing. Urine, a few drugs, the dotted line means that it gets less and less. You might see a few drugs persist for a few weeks in urine, but these are the long-acting compounds that might have been given at pretty high doses, so it takes them a longer time to clear out. We often see some THCs taking their time to clear out as well. So if you're detecting 1,000 THC today, in 3 weeks, you may still have some signal, but you should see a trend, going down if it's really clearing out. Umbilical cord accumulates drug from days to about 6 to 8 weeks. So we move into early months on that. Meconium starts to accumulate in the short term, but you only test it at birth, so it's got a few months worth of accumulation. And then there are some compounds that you can detect in hair, nails, and teeth for forensic purposes. That's why it's in white, not yellow, many years later. So especially the heavy metals. And so we're moving outside of drugs, but we can get into other toxic compounds that you can detect in these other matrices over time because they've been deposited in matrices that are hard to break down. Okay, but in our lab, we're usually using urine and blood and umbilical cord. Right. And then this is different use settings. This is a big busy table just to say, if you want to take a look at it over time. And umbilical cord, we use it on the floors here, but just because of its nature, it's going to happen mostly in a healthcare setting and for a very short period of time. So you're only going to usually see those there. Meconium is a backup method for us. We only have a few infants that we do both tests. So I put that in parentheses. Like, it is common in many institutions. With us, it is the second level test. So this is, I'm not going to spend a lot of time here, but it should help you if you're ever glancing at potential matrices and what to ask about. If I say, yeah, we don't have an oral fluid test for that, it's because we're doing mostly the urine testing and can help with some blood tests. All right, so the question we cannot answer at all in clinical drug testing is, what dose did the patient take? I cannot tell you that. And it's because there's so many complicating factors, of course. I would love to be able to tell you that. I just can't. So it will depend on the formulation of the drug, the route it was administered, the timing, all these things that most of the time the provider doesn't even know. So we have no way to infer that. We would have to know too many things about the patient and their status and their physiology. Just it would be a fun challenge for a pharmacologist, but it would probably still be like, nope. So that's one I can't do. But like I say on the right, we're better at magic 8-ball responses. Like, it looks pretty good. I think it's there. That's kind of the territory we're in most of the time. All right, so common clinical questions. This is very common to the drug testing. Is the drug present? So that you can do a targeted test. It's a compliance check. It's, very specific questions. Is the oxy I'm prescribing present? That we can answer for you. We've got those tests. Therapeutic drug monitoring, of course, we do that all the time. Is the vanc toxic? Is it in a therapeutic range? We're pretty good at those. What drugs are present? That's more of a screening capacity, and we still have some of those. We don't have every drug. We can't do it all. Like kratom, still a no. I still don't have screen for kratom's active compound. Sorry, but yeah, that's that capacity. How much of the drug X is present, as we've already kind of covered. There are ways that we can go, yeah, this is 42 of X. So just depends on our matrix and where the test needs to go to help you get to that number, whether it be here or another laboratory. And then when did the patient take the drug? That becomes one of those window things. Well, if it's present in the urine, it's been there for anywhere from about 12 hours to 3 days. That's about the best I can do for you. But we can try to help narrow that down. And then turnaround is another word that we say. I say that's a long turnaround time or that's a short turnaround time. Screening is short turnaround time. That means we can do it rapidly. That's it. It's just the time it takes to get the sample to get you a result. So a screening, if you order it stat, it's about an hour. If you order a screening panel routine, it's about 4 hours. If you order with confirmation, it'll take that couple of hours to get the screening result, then it reflexes and it goes to our lab, and then we do it tomorrow or Monday if it's a weekend. So it stretches the time out as we go. And then I tell people it depends on workflow. So this becomes manufacturing concepts that a lot of people have never seen in work in the hospital, but it's absolutely in work in the lab. We have stat workflows like your subway, single piece workflow, take a tube, put it down the track, only do the testing needed, only report out what's needed and move on. And every single tube has a different order, and we only do the things that are ordered for that thing. So if a person forgets to order something, there's no result because it wasn't in the order. Routine testing is batched. And I always tell people, you know, when you want a chocolate chip cookie, you usually have to make a batch because the efficiency of making one cookie is usually not worth it. But what you want to do is cross a threshold where it's worth the effort, and then you do that batch. That's mass spec testing. Our confirmatory testing takes 6-point calibrations, lots of quality control, all kinds of carryover checks. We have to be hyper aware of what's going on in the system. So we accumulate a few samples overnight, and we don't just do one at a time. So that's the difference between turnaround times and the workflow approach. And if you ever want to come and see the workflow in action in the laboratory, ask me for a tour. I'm happy to give one. And I have a link to a YouTube there. If you have an active link when you see the presentation, you can fast forward and it talks about workflow and how those things work. So just in case you're curious. All right, then the drug testing examples by workflow, I'm noticing the time, taking a little longer than I should. Single piece workflow is your point of care cups, what comes into my laboratory for screening, and then the batch is going to be the confirmatory, definitive, and anything we send anywhere else. We batch them, hand them to a courier, they ship them, the lab gets them in a batch, so it just keeps going that way. And then availability. This is a long slide to say we can't keep up with drug trends for many of the drug classes. The things that shift around quickly and are always changing, like these novel psychoactive substances, the synthetic benzos, those are so hard for us to nail down. I could not validate fast enough to stay on top of that. So I depend on other laboratories to help me with that work. And then a list of what we have available where is in here. Again, for time, I don't want to just read, and I don't like story time anyway. So when you see these, please ask questions if you have any follow-ups at that point. Interpreting these, I wanted to show you this. This is an anatomy of a drug screening test. I wanted to point out the qualitative result is positive for tramadol. And then we tell you this is intended for medical use only. It means it won't hold up well in a court of law because this is not collected with a chain of custody. It is not put under the forensic rubric. So if it goes to a court of law, it's gonna be like, could these be switched? Potentially, yes. Is it intended for forensic use? No, it's intended for treatment purposes. So we have to put those disclaimers in. This is how the FDA approved this test, is for medical use only. We also warn that positive screens are presumptive, and that if you have an unexpected result, you really should confirm it. And then by regulations, we're supposed to tell you what our decision level is. So in the background, the number we get is a little bit squishy, but this is the cutoff that we used. So that if you ever need to reference it, should be in the report. And then I have a fentanyl example at the bottom that shows the labetalol comment, and we're about to add the thing about antihistamines because we found that antihistamines definitely do cross-react. So that's the anatomy of screen. The pitfalls, cross-reactivity we've covered. So that means over-the-counter, prescription, herbal supplements, all kinds of things can kind of muck up this process. False negatives also possible, which we covered earlier. So I won't dwell too long on that, but think about frequency, dose level, things like that when you're saying, why isn't this present? Also, ritalinic acid is not detected by an amphetamine method, only Adderall. So that will be a negative. I'll keep going. This is how Ruby's confirmatory tests look. If you order an opiates confirmatory, there's a lot of compounds. The things that are bolded are what are reported. We don't report a number if what we get is below the cutoff. We report the number if it's above. So then at the top, we also give you a signature. So we interpret it for you and say the likelihood is greatest that this is oxycodone. And what you might notice is that if there is a simulated compliance where we have only oxy but no nor-oxy is one example, we say this is suspicious for a simulated compliance. So we're trying to put a neon sign on that for you, just to kind of help you through it. And then pitfalls to consider: the panel tests only detect what they're supposed to. Mentioned that already. This takes time. We have human beings extracting drugs, loading them on, looking at tracings, putting in results. This is a highly manual process, and we do about 200 a day now. So it's one person sitting there just looking at curves for hours and hours and hours. Keeping up is kind of fun. They can be adulterated. Like any test or system, you can have patients that try to dilute or try to add something. Last week, I wish I could give this anecdote in great detail, but someone tried to pour Febreze or some kind of air freshener into their urine specimen. It shut down my chemistry analyzer for 6 hours. It caused false results on 25 patients, other patients, and we detected it at the confirmatory bench. So it was 3 days worth of investigation and corrections that had to happen because one person decided that they wanted to avert their results. So this can be a big problem for us. And I was like, why did you even put it on the system if you could smell Febreze from 6 feet away? So we had a lot of chats about that specimen last week. And the cutoffs are really low. So sometimes they're a little bit too sensitive when it comes to confirmatory, and we're trying to right size that. I wish I had time for that anecdote too, but I work with Dr. Barry, and every year I analyze our positives and our negatives, and I try to see where those cutoffs need to lie. So you might have noticed the opiate panel went from 10 nanograms up to 25. We were over detecting for you guys, and it was kind of causing some problems. Okay. All right. Finally, the things we can and cannot do. I'll let you go through that because I am now a little over halfway, and I really don't want to clog up the works further. I want to open it up for Q&A. So basically, there's some things we cannot do. We would love to, and we want to help as much as possible. So please always ask a question, and then we can tell you what we can and cannot do to help you. All right. You can reach me in Epic or by email, and Dr. Jambo Yang is our second chemist. So happy to have him. And if you CC him, if one of us is absent and the other one's present, we'll try to help each other out. Okay. And here's the recommended reading. So I'll flip back to Q&A, see if there's Q's or if I have any A's.
Thank you so much, Danielle. What a wonderful presentation, and you're perfect on time. I don't want you to feel rushed or anything. So you did an awesome job. We did get a chat in. Laura, I didn't know if you wanted to maybe, I'm happy to read it out as well, but I'm sure you're much
That would be great.
Yeah, I'm curious what you would consider like the gold standard, because we do, there are lots of ways to do testing in terms of blood, urine, sweat, saliva, hair. What would you say is really, if we're trying to detect presence and possibly, a quantitative level, what's the gold standard?
I would go for a confirmatory in our space for medical use. If you are relatively certain that you need to know information about a specific drug, going for confirmatory is your better standard. But
what like method in
mass
like
spec,
hair, blood?
That would depend on the drug you're looking for. In your space, it's mostly illicits or potentially misused prescription drugs or some over the counters. I guess they could be associated with dependence. Those would be apt for urine testing. They're relatively stable once they get into the urine matrix, and we can do confirmatory testing at many laboratories. If I don't have it, another lab has it. Urine is the most common matrix. So in your space, urine confirmatory with mass spec would probably be the best way to go. Although when you're trying to counsel a patient and you need to have that discussion right now, I would say using your point of care cup to screen it and then start the dialogue early. I think that's a massive help. And as a laboratorian, we were highly resistant to point of care screening. I have to admit, in the beginning, we were just kind of like, I don't know if this is going to be good. The performance is so weird, and we were so worried. And it's been such a help to start those discussions that we've completely bought in, and we sell it all the time. I talk to my colleagues about how useful the cups can be in intervention work. So I would say both of those, and it kind of depends on what else you're looking for.
Hey, Danielle, I wanted to get your thoughts. If we have a situation where somebody has a very low level show up on, say, a sweat patch or a blood serum, but then they have a corresponding urine that's negative, how would you interpret that?
That's difficult because remember timing. Okay, so sweat patches are going to reflect only the last few hours worth of drug exposure. And then they're going to start to transfer out, unless you're accumulating the sweat patch for many hours, like you're putting it on a person for 24 to 48 hours, and then you're looking at it, then you've lost the specificity on your time window, but you've at least captured it.
I think they leave it on for about 2 weeks.
2 weeks. Okay. So that kind of almost is the same as urine. So if you saw a difference in them, the next question becomes, what kind of drug is it? Does it interface better into the serum compartment? Is it amenable to urine excretion? There are those questions too.
Positive for cocaine at one point, and then I believe there was another one positive for fentanyl a few months before that.
Okay, so then here's the picture I get. You've got a sweat patch on for 2 weeks, and it can catch all of that clearance for 2 weeks in the sweat patch. You catch a urine, you're only catching a potentially 3-day window around that collection time. So you could miss it at the front or the back end with urine. So if a person comes into clinic, they look pretty clean, it's a negative result, but the sweat patch caught it, then they could have done something before or after the time window for the urine collection that could conflict. Blood is even a narrower thing, right? You do a blood collection or a capillary spot, and that is just probably only an hour or so that you're looking at that before it's starting to compartmentalize and the drug is pushing out into different places. So yeah, you can definitely have discrepancies between those matrices, and it has to do with all of those factors. It's a complicated question.
Okay, and is there the potential that, you know, they say they may have been exposed, but that they definitely have not had a relapse? Is that possible?
Oh, I wonder what kind of exposure that would be. If we're talking about a transient transdermal exposure, let's say someone picks up something, they're saying that they were doing the dishes or they were handling some trash and they think that they got an absorption from that. I would think that the dose would be kind of a single bolus that would happen relatively quickly, and then it would clear out within a pretty short period of time. I would think it would never peak like you would get a full, you know, intended intranasal dose if it's cocaine, or, you know, if they are injecting, that would definitely be an immediate bolus that's very large. So I would think that depending on the cutoff, if it's a very low cutoff, extremely sensitive test,
Very low, yeah.
transient exposures could potentially ping it, but then it would be gone within 24 hours, right? Because like I said earlier, dose will affect it because you've got half-lives. If you start out low, you're going to dip low fast. Whereas if you had a bigger dose, it could take multiple half-lives before it's gone. I hope that makes sense.
And I think their concern was the place that they go to that removes the sweat patch is not a sterile environment. It's not very clean. There's tweezers that are used on everyone that comes in that aren't necessarily cleaned. So that was kind of what they were presenting to me.
Like a theory of carryover. It is scientifically plausible, but I have no data. I would think that the limited surface area of the tweezers pulling these patches off, even if they used them on successive patients and one patient had a really high dose of drug X in their patch, transferred a little to the tweezers, and then you transferred it over to the next patch, I think that would be a super low amount. So like I said, as a scientist, I can't say nah to
Right.
that. I just work in risk assessment and plausibility. Plausibly could happen. Likelihood relatively low.
Okay, and then I just wanted one more question. What are your thoughts on the 3-dot blood testing as far as using that for, you know, forensic purposes, punitive purposes, you know, that nature?
So doing a finger stick, 3 falling drops into a card, and then those get sent off and they're doing blood spot testing. That is, again, a very limited window. If it's not a chain of custody, it's easy to dismantle in a court of law. And because someone could say, well, then the cards got switched. That's the first, I mean, no chain of custody. Someone put the wrong name on the wrong one if they were collecting multiple people. There's a line of 10 people getting finger sticks. There's all these cards getting lined up. It would be super easy to put the wrong label on the wrong one. So chain of custody is stringent because you show the patient the label, or the person the label, and then you put it on the sample, and then you show it to them again. This is yours, right? Yes. Okay. That's chain of custody. And then that label's across the card so that it is sealed. Nothing else is getting in there. So the person sees the collection, usually they see it on the medium that is going out, and they see the label go across it, and it is sealed up. So chain of custody is much harder to fool.
Okay, thank you.
Yeah, but the medical use stuff, like I said, we're doing it because we're trying to intervene when a person comes in from a auto collision, or they're coming in and they're asking for help, and we're trying to screen out and see what all is present potentially, and sort out what kind of assistance or intervention is needed. So it's just a completely different spectrum of interest in what we're finding and how we're going to use the information.
And Ryan chatted in as well, saying, I'm dealing with a lot of attorneys who are questioning the reliability of oral swab screens that are sent off for confirmatory testing. And he asked if you can talk about the reliability of these specific screens.
Yeah, oral swabs are fun. Some drugs partition to oral fluid at a greater rate than even renal excretion. Like it'll just phase right into oral fluid. Other things, you can't get them to phase into oral fluid because of the texture, all of the salts and the enzymes present. The matrix of oral fluid is weird enough and different enough from serum that it is going to have a different profile of clearance or drug appearance than, say, urine or sweat. Sweat will have a different profile as well. They just start to, there's still characterization going on with oral fluid and with sweat. So I could see why there are some questions that come up where it was like, well, we had the oral fluid and it told us that there was drug X present, but that is consistent with their RX, but then this other thing happened. I think I was asked to consult on a case where there was an oral fluid and it showed up some stuff that potentially suggested that the domestic partner was taking this one's RX or had some kind of exposure to it. And I was like, there's some things here that from a legal standpoint, I won't be able to go to a court of law and suggest these things, but if you've got a good expert witness, they'll catch those details and they might be able to say something about that. But yeah, oral fluid still a little strange, which is why we don't have any collection devices yet. There's a rapid collection device, but it's like, what do I do with it? What am I going to need to do to stabilize it? And what kind of science do I need to have on my end to make sure it's accurate? And we haven't characterized it yet at our institution. So I wish I could tell you more.
Thank you so much. And I will just read out Tina's comment in case you can't see the chat there, Danielle, but she was just saying really informative. I've learned a lot of information, definitely helpful when providers are questioning certain aspects of test results. So
thanks.
I'll echo that.
It's like drinking from a fire hose. So it's a lot to learn and it's a lot to manage. And if you only have so much time with each person each day and you're trying to manage a bunch of cases or a bunch of work, also learning about toxicology. And I say that y'all aren't in the game to have a double major in pharmacology. This is just difficult stuff. So please ask for help.
Absolutely. Thank you so much. We have about 15 minutes left. I wanted to leave some time for the case as well, but did anyone else have any final comments, questions about this discussion and Danielle's presentation?
I do have a quick question.
Okay.
I was wondering, and it's my understanding that you probably send cords out for testing. Is that correct? So like we had a client that she admitted to regular methamphetamine use throughout the pregnancy, but yet the baby's cord came back negative or anything. So could you explain how that could happen? Or
it goes back to partitioning to how these drugs can move from one compartment to another. There are some drugs that don't move into the umbilical cord tissue as well as, say, meconium. And that would be cases where you might want to get both, if you can possibly test both matrices to see if maybe you have a situation where the newborn might need some clinical support. Or if you're trying to track that down and get evidence, maybe a meconium would be a better format for some drugs and not others. Umbilical cord is better at catching some other drugs than meconium. It's kind of a trade-off. But there are several papers about that out there. I could potentially find a couple of those and send them to you to show that the false result rates vary between the two media and they kind of trade off.
Okay. So is it fair to say though, that if something shows up positive in the cord, that it was truly there, does there need to be any kind of confirmatory thing done with that? Or is it pretty for sure that it was there, but just because it's not in the cord doesn't mean the mom did not do those types? I mean, like, she's admitting that she's done this and she wants help.
Yeah.
So I just want to make sure that they're not dismissed by saying, oh, well, it wasn't in the cord. So
yeah, these medical use tests, especially in cord, remember cord's recording time frame is from the moments around birth back about 6 to 8 weeks. So if they received help and they started to abstain at that early period, you would expect the umbilical cord to be negative. But if they had used in the weeks prior to that, then meconium should have gotten it. These tests are done mostly by mass spec. The one that we get, the screening for all but one of the drugs, is by mass spec. The other one is an immunoassay because they actually can detect it better in the immunoassay. But they're considered definitive tests because they don't give you the dose, but they give you that signature. So they say this patient definitely had zolpidem and present. So that's like a high resolution mass spectrometry definitive method that won't give you I always use 42 because I'm a Douglas Adams person, but it wasn't present at 42. Also, if there was a clearance going on as the accumulation started, the dose may be low enough, it might be below cutoff. So you might just have a false negative because of low cutoff or because of a cutoff issue. So yeah, they're about as definitive as they get. There are a couple of labs that do chain of custody, umbilical cord, and meconium tests. They take a bit longer to produce results because of the chain of custody, the stringency needed to push it through that process. And they probably give quantitative numbers in the reports. So they probably go lower and give the number in the report. If you've got a situation like that, you might want to set up an order for that kind of test before there's even a delivery, if it's possible. Or if you can intercept the umbilical cord and try to get it out, or the meconium and try to get it out for chain of custody, it might be your best route for those.
yeah, our local hospital, I'm almost positive they do a chain of custody with the umbilical cord.
Yeah, we've been discussing at a system level. Ruby's doesn't, but there's 2 or 3 hospitals that do chain of custody. Sometimes the labor and delivery group establish the chain of custody and send it out. Sometimes it goes to the lab. We're trying to look at a standardization of the workflow to see what might help. Some site is going to end up losing, quote unquote, some part of that service in a standardization. So far I haven't really touched it. I've been like, if the institution is fine with that workflow, I don't want to step on it. But if pressure is put on me for standardization, which that's another hat I wear, it's to try to make sure that all offerings at all sites are equal, then I might have to assess it at some point.
Thank you.
Janine chatted in as well. The statewide umbilical cord tissue test was done in 2009. Didn't show any methamphetamine exposure either.
Yeah, I used that paper in a paper I wrote about Ruby's program because we started ours in 2013 and we were using a different laboratory that included methamphetamine as well as amphetamine and some other stimulants. And we went, oh, this is kind of interesting, isn't it? You know, just the gap in the data and the cases we started to catch just because of regional use patterns. We started to see spikes that would decline and shift around. So some pretty interesting data that's come through our program, although we only looked at our institution because our screening program is universal. So
yeah, we were always curious about why meth didn't show up at all in any of those. And that was it was universal for 8 hospitals in 1 month's time. So
Yeah, and it's mostly because methamphetamine is rapidly metabolized to amphetamine. So you're just going to get an amphetamine signature in many of the patients. So you end up losing the meth group and it just looks like amphetamine.
mm.
But
yeah, and I
if-
wonder, because I think I'm sure Cabell Huntington Hospital is using the same lab that was used in that study. So I'm wondering about their testing. Yeah.
Interesting. Yeah, you've got to think about how the drug moves through and how it gets changed, altered, and cleared. And yeah, if it's a really rapid compound, you might not be able to catch it. It might be like a fairy flight through the body and hard to deposit in a high lipid matrix like meconium or a tissue-based matrix like umbilical.
So are you saying that meconium might miss it as well? Or do you think it would be a better?
Amphetamine is rapidly cleared. It might be really hard to partition to meconium efficiently because mom might be taking care of it before it can really deposit in baby. So it's possible. And it's very small compound. So it might be able to cross back and forth and not stay still long enough to deposit. So there could be some dynamics there that are weird.
So much. Any other comments, questions from the group? And everyone's welcome to chime in.
But there's a case.
Yes, we have a case. We can always save it for next time as well. So Laura and I were just chatting. We don't want anyone to feel rushed because the discussion is always so wonderful. So
If I had the emoji, it would be the one going right now.
no, not at all. We so appreciate your time and sharing your expertise with the group. So my emoji will be a big smile, not that one.
Is there anything?
I have a question. So my job often involves reviewing a lot of records, forensic world, but doing evaluations on people involved in the court system. And so I'm reviewing a lot of records from a lot of different, could be hospital systems, not Ruby, not WV Medicine, but other places. Are there things to look out for that would suggest maybe I should be a little hesitant or cautious in looking at a drug test result? Like, is there anything that would tell you, oh, this was good testing, or maybe this wasn't very good testing?
I like to look at the features of the report. If the laboratory is one that is relatively prominent, you've got a medical director's name at the bottom of the report, like they tell you, they're transparent about their methods, they tell you what the method used is, then those tend to be laboratories that are trying really hard to meet regulatory rubrics that will, that are about transparency and communication. Those laboratories tend to be more stringent in their quality control. It's just kind of a pattern you see. And like me as an inspector for clinical laboratories, I walk around and I say, let me see a few reports. And that's usually the first thing I look at is, how does a report read? Do I know who to ask a question to? Who's the director of the lab and things like that. If that is above board and I'm not getting some mysterious answer and it's just not telling me anything else about it, I usually feel a lot better. And then I also look at how clinical notes are kept, personally in my space, because I'm in clinical charts. But if there are other file work, if there's other things that you're digging through and you're not seeing thorough notations, it's kind of like, was this done in a hurry? Was how much wavelength did the person give to that particular task? Testing is similar. So if it was rushed, could it have been switched? Is this the only one that's ever happened in this patient? Was it the only time it ever went to that lab? Is it different technology? Are they using different cutoffs? Like there's a lot of questions that bloom when you start to look at those. So I would say always try to look at the format of what you're looking at. And if it seems like information is missing, then dig. So yeah, I hope that's specific enough.
Yeah, that's helpful. Thank you.
Mm-hmm.
Hey, Danielle. So, sorry, another question.
Don't be sorry. That's why I'm here.
So there was, in one of the cases, I was present in the courtroom, and there was an argument that CLIA certified labs are the best for forensic purposes. Is that accurate?
No. There's CLIA certified labs are what we're doing in medical laboratories, right? There are forensic labs that can be CLIA certified, and they should have a CLIA certification, because all laboratories doing any kind of clinical work should be registered with CLIA. Okay, so that's step one. All CLIA laboratories also need to be accredited through someone who's going to inspect them. All right, so that opens up a bunch of avenues. If they're doing forensic work, then they have to have a forensic level inspection, and it can be by a couple of agencies. That could be, that there's some categories that you get into there. So CLIA certification is step one. That just means they have a lab and they have a number and they bill, because CLIA certification is about being able to bill and get money back. Okay, and then the rest of it is about the regulatory structure, the rubric that they follow, the stringency, and forensic level testing and inspections have a much higher demand than for specific types of data handling than what we have in the clinical lab. Example, they've asked me if I want to do forensic toxicology here, and I said that would be lovely, but I would need a second board certification. I would have to board certify in forensic tox. I would have to have dedicated continuing education just for that program. I would have to be the certifying scientist, so I would have to look at every report that comes out and sign off on it. We would have to have a lockdown of PHI, a separate information system, a separate facility. We would have to have chain of custody for everything. That means lockboxes for all of the samples too. We don't have that kind of facility here. So that's why, big reason Ruby has no forensic capacity. We can't make that float right now. So those forensic labs have those requirements, and an inspector will come in and say, I need to see a report. I need to make sure that the right people signed off on the curves or whatever outputs came out of the analyzer. How did they control that day? How was everything in? Is everything documented to a T? Those are the successful labs, and those are the best ones for your medical legal testing.
Okay. And have you had any experience with like OPANS labs or Redwood? Any of those sound familiar?
I haven't directly worked with them, so I'm not familiar. The lab I have the most familiarity with which I have the most familiarity that has a forensic capacity and also a clinical one is NMS, and so I'm much more familiar with their workings. And I also knew their technical director a few years ago. He's since left, but yeah, you get where these are your colleagues and you get to know them pretty well. I know them. I know LabCorp's forensic arm director, Jen Colby, very smart lady, super smart. So, but yeah, not Redwood. And the other one, I haven't.
Yeah, OPANS, they have a contract with Day Report, and they usually are on the witness stand, and kind of, I think that's been something, at least from my point of view, this person profits from this test, and I'm not sure that they should be.
That might be a conflict of interest.
Right. Yeah.
Maybe an outside expert to come in and review would be a good thing for cases. If I had the training, I would love to help with those types of things. We've interacted and I've been like, we have to talk to legal because it's not me, I can't do it. But yeah, it's always good to have an outside witness who can review the workflow and look at the reports and sit there and go, yeah, this follows that rubric, and I think it's a good test and it's probably accurate, or I see some problems here and here's what they are, and explain that.
Yeah, and I did want to say I appreciate your referral for the outside experts, because we did actually end up using that, and we were able to obtain one for a previous hearing. So that came in handy.
Yeah, having access to the right experts can be really difficult, especially if the time frame is narrow. And so being able to call up a person and say, could you please take a look at this, at least review the case and give some feedback, that would be great. I just, I believe in advocating as much as possible, because it's not my role to judge. It's just to say, this is either what I see or I don't see. So
thank you.
Righty, well, we are at the top of the hour. Any final comments or questions you all have, you're always more than welcome to email myself or Jay's email as well. I'll make sure to have those addressed for you and sent back to you as soon as possible. Just wanted to give you a big shout out, Danielle, for joining us today and presenting yet another wonderful ECHO presentation. And we so appreciate your time in joining us today. And also wanted to Yeah, no, absolutely. Thank you.
Thank you.
Appreciate each and every one of you as well for joining the session and contributing to the awesome discussion we had today with the questions and comments. So thank you all so, so much. My only announcement is that the next session will be on August 16th. So Jay will be sending out some information regarding that session as the date approaches. So thank you all. I hope you have an awesome rest of your day and week, and we'll see you next time. Thanks, everyone.
Bye.
Bye.